Did you know that 9 out of 10 people experience evaporative dry eye associated with meibomian gland dysfunction? Are you aware that there are tons of causes out there, such as high screen time and even certain medications? We have to do something about it. As eye care professionals, it's our job, but it's also an opportunity to help elevate that patient experience. On today's podcast, we're going to talk about a solution to help manage and treat evaporative dry eye. Let's go. This is a Defocus Media production. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus.
Hello, and welcome to a new episode of the Defocus Media Podcast. I'm Dr. Jennifer Lyerly, and I'm joined with my partner and friend, Dr. Daryl Glover, to talk about a topic that is really near and dear to what we do in eye care, dry eye. I know you, this many years later, Daryl, how excited do you get about a dry eye topic?
You know what? I actually get super excited. It's the one thing that I get excited about next to, of course, my kids and my beautiful wife, right? So I'm not saying they're right beside each other, but let's say I get pretty excited, Jen. How about yourself?
Yeah, you cannot do eye care without addressing dry eye, and our tools to be able to treat dry eye have skyrocketed during the course of our career. So I think this is a topic that continues to excite because we continue to have new things to talk about. Tonight's episode being no exception to that, and we have an expert guest. You guys know her as the famous Eye Dr. Mila on Instagram, but welcome to the show, Dr. Mila Ioussifova.
Thank you so much for having me.
We're so excited to have you on. Before we started recording, we were talking about, I feel like I know you because I've been following you online for so long, but this is our first time recording together, so this is a real treat for us.
Yes, I know. That's the beauty of social media, right? We get to know each other really well, and then when we actually meet in person, in real life, we're like, wait, we feel like we've known each other for years.
Yeah.
How did you find a passion for dry eye in your practice?
So I think I probably have a similar story to everyone who really is passionate about dry eye, either a personal, I started to actually have symptoms of dry eye after optometry school. And, slowly I was not able to tolerate contact lenses. And I was like, oh, let me try different contact lenses, kind of same story we hear from our patients too, coming in saying, these lenses don't work anymore. Let's try something else. And then also my mother has Sjogren's and she has dry eye. So really, really personal experience with dealing with dry eye, but also, patients really in my practice. When I opened my practice, it was a cold start practice 12 years ago now.
Did you know when you were going to optometry school that cold starting your old practice was what you were going to do? Or how did you make that big jump in?
Not at all. I actually thought that I would never own a practice. I thought that I would just join, a group practice. I was all about disease. I did a residency in the community health center, so I really got to see all sorts of disease. This was in Boston. And I thought that coming out, I would just, join a big practice. I would see a lot of posterior I loved posterior segment. I wanted to see a lot of retina, glaucoma. And then when I opened, so I practiced for about 4 or 5 years. 3 years into practice is when I was like, I think I want to do my own thing. So I had a little bit of experience. I was also an adjunct clinical faculty at Pacific University. So I still got to see some disease. I got my, that fix of seeing more complicated posterior segment. But I really wanted to have something that was mine that I could build and bring in the equipment that I wanted, some of the early, and I was, again, lucky enough that when I opened the practice, dry eye was kind of starting. This was 12 years ago. And, like pretty much second year into it, I got LipiFlow, I had MIEBO, and then year 4th or something like that, I got IPL. So I was one of the early adopters, and it was really interesting when I was talking to patients about IPL back in, 2017. They would look at me like, what are you talking about? Whereas now we have so many resources, and, now that it's a well-known treatment, so the discussion is much easier. So it was harder to implement some of those things early on, but also I was happy to, again, have these tools where I could treat my patients, really treat the root cause of the problem.
I love that. I love that. And I love that you're focusing everything around the patient. I mean, that's how you just ended that last remark, right? And what I would like to do next is really take a tour through your office, because it sounds like you have all the right bells and whistles to really, target these dry eye patients. So let's take a tour through your office, if you don't mind.
Sure. Hi, welcome to South Evaporative Eye Care. Come on in, let me show you around. This is our front lobby, and we have Stacy, our patient coordinator. And here we have Esther, our retail manager. And let me show you around over here. This is our optical, and we carry independent frame lines. Okay, so this is where we do all of our dry eye treatments. We actually have a patient having a treatment. She's getting a low-level light treatment. And this is our advanced esthetician, Sydney. She does all of our treatments. We do IPL treatment here, radio frequency. We also do some aesthetics, microneedling, RF, and hydrofacial. And then we do lipoflow, MIEBO tear care. And we also do blood draws in this room and prepare autologous serum and autologous PRP eye drops, which I'll show you where that's done. So let's go to the back. Okay, so this is my exam room. Virtual assistant Joanna on the screen. Okay, I'll show you where our pre-test room is. This is Marina. She's my technician. She does all of our pre-testing and also working with patients, patient coordinating. One of the things that we do for all of our patients, other than just our normal pre-testing that's done in regular eye exam settings, we also check glands on every single patient. So we do meibography on every single patient coming in. For dry eye patients, we'll do more testing like tear osmolarity testing with Tear Lab. Also check carotenoid levels for patients. We talk about nutrition and lifestyle. One other test we have that checks the misalignment in patients' eyes is Neuralens, and this has been a very helpful tool for us to do on patients that may have eye strain and headaches and even dry eye symptoms that are not improving with the treatments that we perform. So once we do the blood draw on patients, this is the area that we use to make autologous serum or autologous PRP eye drop. Everything has to be done in a sterile environment, so this is where we use the hood to prepare the drops. This is a hematology analyzer, so for PRP preparations, it's important that we measure the platelet count, and that's what this is for. And obviously, this is a centrifuge. And we keep them in the freezer if the patient has to come back, but if a lot of times we just prepared and they have their drops within an hour or so. So it's very convenient.
In your beautiful office now, tell us a little bit about the patient journey. What is the flow looking like to the point where they're going to the office, getting to you, and you're making diagnosis and treatment?
So the patient journey starts with the phone call, right? So when the patient calls the office, my staff already knows to ask the right questions to determine if they're calling in when they're complaining that their vision is blurry. Is it a refractive problem or is it an ocular surface problem? So they'll ask them, is your vision fluctuating throughout the day? Are you not tolerating your contact lenses? So those are the questions that, we have a script for our staff where they can already gauge what kind of appointment this needs to be. So they can have that discussion with the patient that Dr. Mila may actually be doing a medical exam on your eyes and with you and treating if there's an underlying problem like dry eye problem. And a lot of times patients will be like, oh yeah, my eyes have been dry. And so again, that phone call really determines what kind of appointment we're going to do. So once the patient is in the office, they actually, before they come in, we electronically send questionnaires. So the patients will do their medical history questionnaire, but also we have speed questionnaire already built into that. So every single patient fills out a speed questionnaire. So before they're in my chair, I already know how symptomatic they are and whether I'm going to do the next step in doing some dry eye testing.
We got to spend a little bit of time on this because, Jen, I don't know about you, but my mind is blown. I don't know about you, Jen, but sometimes what can happen is when a patient comes in and we're doing the refraction, we know their eyes are dry, and then we got to pivot that conversation about how we're going to manage the dry eyes. But now with this approach, before they even walk into the exam room, we're taking out all the headache, we're taking out all the speculation of what's going to happen from the patient perspective, and we're able to get down to really managing dry eyes. I think this is phenomenal because when the patient comes in, they know what to expect. And plus, you got all that data that's cooked up in front of you to be able to have a real solid conversation with that patient. So I love this approach. I thought I was, making the magic happen by understanding how to pivot that conversation in that exam room. But now I know I got to take it a step further. I mean, what are your thoughts?
I think this is the advantage of a specialty practice, right? Like you're not presenting to the patients as like, this is just your 15-minute eye exam. You're creating from the start, from the very first phone call, we specialize in dry eye. The patient knows that when they book the appointment, they know that it's a focus. It's most likely the reason that they're there. And it really does separate you as this is a dry eye specialty office and not just a regular eye exam you can get anywhere else. And so I do think when you're marketing yourself as a specialty, you have to make it a specialty every step of the way. And you clearly have embraced that in your success.
I love it. I love it. Let's continue the journey because I'm getting excited over here.
And Daryl, what you said is so true. And this is why I actually never refract patients until I take a look at their corneas. So I do fluorescein staining on every single patient, not fluoresce. We don't want to flood the corneal surface or, and numb it. So I will, once we do the pre-testing with my tech, the tech will bring in the patient, check VAs, and then I come in, start talking, and I do fluorescein dye on the corneal surface first. So I want to look at their cornea. If they have SBK, especially central SBK, I am not spending any time refracting. I don't want to waste my time. I don't want to waste their time. Oh. So I'll look at the corneas first, and then we'll proceed to do refraction if it's truly a vision type of, comprehensive exam. Yeah. For patients that are finding me either referred by colleagues, they're coming specifically for dry eye. And this is very different type of appointment because I'm not spending any, I'll check their VAs and then move on. Those patients get both fluorescein and lissamine green staining. We do tear lab osmolarity testing on every single patient or dry eye patient that's referred to me. And we'll also check the inflammatory markers. I mean, there's a really big value in showing images, right? That's why we do meibography on every single patient, not just dry eye patient. Everyone who's coming in for comprehensive, we do meibography. I pull them up in the exam room. I go over the glands, what the normal look should look like, where they are, talking about it. Again, with dry eye patients, that this is very important too because they know a lot about dry eye. They come in and they want to see, have they progressed? Have they, changed and things like that. So doing that on an annual basis is helpful for them to understand, have we stopped this progression? Another thing that I do in my office is I have a virtual scribe, which is so valuable because when I'm talking to patients, and these patients, especially those that have had dry eye for a long time, the statistics say that on average, dry eye patients see 3 to 4 doctors before they get relief. And wow. The majority of them are really frustrated with the lack of, treatment options, but also lack of support and empathy. And so a lot of times, and I hear this a lot from my dry eye patients that I've seen so many optometrists, ophthalmologists, nobody understands, their families don't understand. So my dry eye appointments are an hour long, the first one. And follow-ups maybe 30 minutes, but sometimes, again, some patients do need a lot of time. So I sit there and I listen to them. I really understand when this problem started, when, what kind of things I've tried. And so there's no way I could basically record everything if I was just charting myself. My face would just be in the computer, right? So having a virtual scribe really makes me be there for my patients so I can sit there and listen to them eye to eye, understand, everything and give them the support that they need. And my scribe just records everything. It's the best thing ever. And then at the end of the exam, patients have their their treatment plan, they understand everything just gets printed, so they don't have to take notes or, things like that. So that part is really, I encourage any of my colleagues to really look into having a scribe. I mean, I've had physical scribes for many years, but having a virtual one has been even better.
Yeah, I mean, I love that approach, and I love that you're really giving that patient 100% of your time. You're putting them on a pedestal, you're looking them in the eyes, you're practicing empathy, you're practicing compassion. Jen and I have been doing a couple of podcasts on dry eyes. We've been blessed to partner with Bausch & Lomb, and again on this podcast as well. And when on the previous podcast, those two words were mentioned as well, empathy and compassion. So when it comes to dry eyes, all my eye care professionals out there, you really got to step your game up and make sure you're practicing this because these patients need it. And I want to thank our partners, Bausch & Lomb, for making this podcast possible. So let's kick it to our partners, if you don't mind, ladies. Looking for a different approach in dry eye? Consider MIEBO, perfluorohexyloctane ophthalmic solution for treating the signs and symptoms of dry eye disease. MIEBO, unlike other prescription drops, directly targets tear evaporation. Learn more at meibomian.com. MIEBO should not be administered while wearing contact lenses. They should be removed before use and for at least 30 minutes after administration of MIEBO. In clinical trials, blurred vision and conjunctival redness were reported in 1% to 3% of patients. Please stay tuned for important safety information at the end of this podcast. Please see full prescribing information for MIEBO at meibo-ecp.com.
Of innovation, there's so much innovation happening at Bausch & Lomb. We know that there's a lot of factors going into the dry eye state of our patients. We've got the nutritional component of it. We know that gut microbiome and systemic inflammation is a huge core issue. Work environment and lifestyles are playing a role. 86% of people with dry eye disease have meibomian gland dysfunction. So evaporative dry eye is a core issue going on in the overwhelming majority of our patients. And that's probably why you're running a meibography on every single one of your patients that comes in, because we know it's something our patients have. But I feel like so many of our treatments have focused on inflammation, which is great. We've got to target that. But we've always struggled to target evaporation, which is such a core part of the problem. And I think that's what makes MIEBO so exciting.
Yeah, you're absolutely right. I mean, the question is, I always like to understand why, right? Why do we have inflammation? How do we get to that? That's all of our treatments are kind of downstream treatments, right? When you have that desiccating stress on the ocular surface, if you don't have enough of your tear volume or the quality tears, you're going to have that desiccating stress. You're going to have increased hyperosmolarity. That's going to, or increase osmolarity, hyperosmolarity, and that's going to trigger inflammatory mediators. And then that's going to, we're going to get into this vicious cycle of inflammation. And now we're introducing anti-inflammatory eye drops kind of downstream. If we don't do that, the corneal nerves get affected. Now we're dealing with a bigger problem, that can lead to NK. So starting early is how we prevent getting down to that, problem, right? So starting with stabilizing the tear film. So what I love about MIEBO is that it really fits into any level, any state of the disease. So early on, when you're looking at the glands, again, it's important to not only do meibography, look at the structure of the glands, but you have to push on the glands. So using a tool to push on the lids to see structurally how they're doing. You can have beautiful looking glands on meibography, but if you push on the lids and nothing comes out, or it's really thick and inspissated oil, that's not good. So while you're doing whether it's in-office treatments or home therapy for these patients, MIEBO already can be started early on, because we know that it mimics our natural lipid layer of our tear film, and that's what keeps our tears from evaporating. That's what keeps the stability on the tear film. So by introducing something that is mimicking our natural meibom, we can stabilize the tear film so that, again, we're not leading into that downstream effect of hyperosmolarity, inflammation, and corneal surface damage. And what I love, again, about it is that it could be in the mild cases, moderate, and in late stages. So I really don't hesitate to introduce it early, especially if you're doing those in-office point of care testing, like measuring the osmolarity level. So if those are elevated, we know that we have an unstable tear film. And we know that artificial tears, they evaporate. We know that MIEBO lasts up to 6 hours, so it has a longer residence time, and It helps with reducing the shear force of the blinks. Again, reducing that friction between the eyelid and the ocular surface, which causes more damage, causes more inflammation.
Yeah. Now, this is music to my ears. And Jen, I feel like I need to step my game up in prescribing. I was probably waiting a little more moderate to severe before I actually started prescribing it. But when we go back and look at the data and how much people actually have evaporative dry eye, I probably should get started a little earlier. I'm curious to know, when you're having this conversation with your patients, what does that conversation look like? Are you met with any objections? And if you are, how do you counter those objections when you educate these patients on how to use these drops? I'm just curious to know what that exam conversation looks like, if you don't mind sharing.
Listening to the patient, obviously, if they're telling me that they're constantly using drops, they're walking around with the vials of artificial tears in their pockets, they can't go to any air-conditioned spaces because their eyes are really burning. So those are, again, without even testing, just listening to patients and asking the right questions already makes me think, okay, this is a good candidate for MIEBO, because with 4 times a day, their clinical data was very strong on showing statistically significant improvement on signs and symptoms as early as 2 weeks. So again, patients that are struggling and they've been using drops and they've been struggling for many years, if you can give them relief within 2 weeks, I mean, that's amazing, right? So that's kind of, what I lead with is saying, like, I hear that you're using drops all the time. And especially if they're coming in using like some other artificial tears that have, mineral oils in them, which is kind of, they've maybe searched for that, or their previous eye doctor recommended some artificial tears that have mineral oils because that helps to stabilize the tear film. But again, we know that they don't last long. They're mostly water, which evaporates fast, and they have very little oil. And that's not really, again, at the same level as what MIEBO does. So looking at what they're using, looking at, the glands, their tear breakup time, their osmolarity. But a lot of times, again, like I said, I can already tell who's going to be a good candidate just by listening to how their eyes feel throughout the day. One of my favorite questions to ask the patient is, walk me through your day. When you wake up, how do your eyes feel? And then walk me through the day, and that again, I can get a beautiful picture of what is happening in patient's ocular surface, just having them like say, oh, when I go to the store, my my eyes hurt, or when I'm driving, or at the end of the day, so again, by knowing how their eyes perform throughout the day, and that way I can tailor my treatments to improve the quality of their life, like day-to-day life that they're doing, they're having, how I can tailor my treatments so that I can take some of that burden of using the drops throughout the day from them.
Something that I like about that, and my dad taught me this at an early age, is that, and he would do this to me, is that, to your point, let people walk you through the day, but let them almost figure out what the problem is themselves, because they're going to start talking about, well, I sit underneath the fan at work, and hold on, that's when my eyes get very dry, right? Or I'm in the vehicle and the vent's blowing towards my face, and it's always the right eye that's drying out a little bit more, and the vent is blowing from that side. So it really helps them to buy into the management of the dry eyes, and I'm pretty sure they'll probably be more compliant with the medication as well, because now they feel like they're a partner, and the doctor is just not telling them, you need to use this drop to manage your dry eyes, to treat your dry eyes. They now feel a part of the equation and a true partner when it comes to the management.
Absolutely. Yeah.
I really love how you're embracing MIEBO in your practice, because it's really similar to how I've been presenting it and embracing it to my patients. When you are prescribing MIEBO for your patients, do you have a protocol regimen, or how are you seeing the results and checking in with patients?
So I share with them that, in their clinical trials, the improvements were seen as early as 2 weeks. And then using it 4 times a day, but also continue to improve at day 56, which was their endpoint. So 2 months. So 1 month is usually my follow-up with a lot of my patients, because again, I kind of set expectations that you're going to start feeling as early as 2 weeks. You got to use it 4 times a day, but I may not want to see them in 2 weeks just yet, so 1 month tends to be a better follow-up for most patients. I don't go past a month because I want to make sure that they were able to get their medication, that they're using it properly, and then there are, not having any adverse events and things like that. So a month is usually what I do. If you have follow-ups longer, I found that patients, they may be diligent about using the drops 4 times a day the first couple of weeks, but they're feeling better, and then they may drop off and, use it kind of as needed.
Yeah, I like to always bring back my patients more frequently. I like to be in their face and just remind them. I will annoy them, but they'll say, all right, Dr. Glover, I'm doing it 4 times a day. I'll continue to do it. But at least I know they're consistent. At least I know they're getting the care that they need. And at least I know that they're going to be able to see sharply and clearly because that tear film is healthier. So I'm all about that follow-up. I typically do about a month out, just simply because some folks may wait to, get the medication or start the medication. So just to give them that little bit of wiggle room. Especially knowing that it's effective after 2 weeks of use. Jen, what are you doing?
Yeah, similar. I will say, typically I'm doing a 1 month dry eye follow-up, but if they were a patient that came in thinking they were coming in for a refractive exam, we weren't getting good results with vision, and because I have not been smart enough to check the cornea before I retract, and just learned something new to do today.
I love it. Well, if you could leave one tip for all our colleagues out there in regards to managing and treating evaporative dry eye, what would it be?
Everyone has evaporative dry eye until proven otherwise. It's so common. Once you start looking for it, pushing on the glands, again, it's a nice bonus to have a meibography because patients like to see things. So if you can have a meibographer, great, but at least pushing on the glands and really assessing and put down numbers, like how many glands are actually releasing clear oil. And as those numbers change, you let patient know, hey, it's getting worse. And so, and don't sit on it, and, implement treatments early. And now that we have something with strong clinical data, with also, we've seen in our own clinical experience how much it's helped all levels of dry eye, starting in early. But also, one thing we didn't talk about is checking corneal nerves. It's so important to check corneal nerves. On all my dry eye patients, I check corneal nerves because, again, if the cornea is not healing, there's now nerve damage. So by using MIEBO early on, we can prevent that. But once we have these, really advanced cases, then we may have to do a lot more than that. But I guess my advice is that it's very prevalent. Just look for it.
I love it. I love it. Well, Jen, I don't know about you, but I felt like I just got a master class on dry eye.
She's
and
a certified nutrition specialist. You did.
Right. And I feel like I have all the right tools and resources in my tool belt to combat any patient that walks into my practice with evaporative dry eye. Like you, Jen, MIEBO has really changed and elevated my practice, especially for those patients that, struggle on that refraction. Dr. Mila, thank you so much for hanging out with us today. This has been fantastic. We look forward to, partnering with you again at some point in time in the near future, because we know you have all the answers when it comes to dry eye. And for our colleagues out there, make sure you tap in. It's your favorite optometrist, Dr. Daryl Glover, and the lovely Dr. Jennifer Lyerly. Stay healthy, stay positive, and blessed. And until next time, peace.
All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the Defocus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars. And make sure you follow us on all social media platforms. Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at Defocus Media on all platforms. And until next time, be sure to keep it 2020. And we look forward to seeing you on the next episode. Indication, MIEBO. Perfluorohexyloctane ophthalmic solution is indicated for the treatment of the signs and symptoms of dry eye disease. Important safety information. MIEBO should not be administered while wearing contact lenses. Contact lenses should be removed before use and for at least 30 minutes after administration of MIEBO. Instruct patients to instill 1 drop of MIEBO into each eye 4 times daily. The safety and efficacy in pediatric patients below the age of 18 have not been established. The most common ocular adverse reaction was blurred vision. 1% to 3% of patients reported blurred vision and conjunctival redness. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see full prescribing information for MIEBO at meibo-ecp.com.